Hello, my name is Veronica Adrogue. I'm an Associate Professor of Pharmacy Practice and the Director for the Community Engagement Core of the NIH-funded Center for Biomedical and Minority Health Research here at Texas Southern University. I want to say a big thank you to you and the community members for joining us for today's program. We are really excited that we will be sharing a lot of great information alongside the experts or speakers and panelists that will be leading us into this conversation. So please have your questions ready. We would have an opportunity to take your questions after today's presentations. So thank you again for joining us, and we look forward to our continued collaboration. Thank you.
Good morning, everyone. Welcome, welcome, welcome. I am Virgil Elkins, the Project Manager for Texas Southern University Center for Biomedical Minority Health Research, and welcome to the TSU Community Engagement Course Chronic Kidney Disease Seminar, Understanding Causes, Stages, Risk Factors, and Strategies for Prevention and Management. All right, so we'll get started first with the general announcements. Again, welcome to today's health education seminar. There will be a Q&A session at the end. We'll have the guest speaker, Dr. Adrogue from Houston Methodist, come up and talk to you guys about chronic kidney disease. Following that, we'll have a panel discussion from real life experiences, people who have experienced chronic kidney disease, to tell you about what they've gone through. Also, for our viewers online, if you have any questions, we have someone monitoring the chat box. So put all your questions in the chat box and we'll try to answer them here on site. So I want to first take time out to recognize J.D. Walker Community Center and also thank them for allowing us to be here. I want to give you a little bit of a background of J.D. Walker Community Center, which is located at 7613 Wade Road in Baytown, Texas. The J.D. Walker Community Center has been a cornerstone of the McNair neighborhood since 1978. It's named in honor of the late Mr. Jefferson D. Walker, a respected educator, community leader, and member of the Harris County Housing Authority Board. The center has served long as a gathering place for residents and visitors alike. Situated within the Edna May Washington Park, the center became a beloved landmark with an expansion completed in June 1993 to accommodate growing community needs. Open daily to the public, the J.D. Walker Community Center offers a wide range of activities designed to engage, educate, and empower individuals of all ages. From youth programs to senior activities, our dedicated staff and facilitators work to create a safe, healthy, and fun environment for everyone. Whether you're hosting an event or participating in one of our programs, the J.D. Walker Community Center is a perfect place to connect, learn, and grow within the community. Welcome to the J.D. Walker Community Center. I want to next take the time out to introduce my colleague, Mr. Mark Garza, who will go over Equitable Breakthroughs in Medicine Development Program here at TSU. Mr. Garza.
Thank you so much, Virgil, for that introduction. Like he said, my name is Mark Ibarra. I'm the Clinical Research Coordinator at Texas Southern University. Currently, we are working and developing a program called the Equitable Breakthroughs in Medicine Development Program. We are working very closely with UTMB, who is proficient in clinical trials. That's something that we hope to be pretty soon. We, as a site, have never conducted clinical research with human subjects before. So we're looking to bring that to the community of Houston through Texas Southern University. If you guys would like some more information on the program and to kind of stay in touch on how we're doing with the implementation of the program, definitely feel free to scan this QR code, or you could contact us at the number that you see here, 713-313-1233, just to ask us any questions that you may have, whether it's what type of clinical trials we plan to do, what the timeline is looking like, or any other questions that you guys may have. Thank you so much.
Thank you, Mr. Garza. All right, again, welcome to our health education seminar. I'm excited for the information that will be presented to you guys. This is very, very important information, as we know that chronic kidney disease does affect our respective communities. Before we get started, just want to remind you guys, for our online community as well as in person, make sure you are, let me start off with our Zoom community. Make sure you sign in using the link, complete the survey, And then also for our CHW participants, make sure you sign in using the link as well. I believe there's a separate link for you. And then if you complete if you complete the survey and stay to the full capacity of the program today, you qualify to win a $15 gift card. We will be giving out $15 gift cards to our first 30 eligible in-person attendees. So this will be for our in-person attendees. All right, without further ado, I want to introduce to you guys our guest speaker today, Dr. Horatio Adrogue. Adrogue. I'm saying it correct? Okay, perfect. He is with Houston Methodist Hospital. So Dr. Adrogue is a highly respected and accomplished nephrologist based in Houston, Texas, with over 2 decades of experience in diagnosis, treatment, and management of kidney disease. Affiliated with prestigious institutions such as Houston Methodist Hospital and Baylor St. Luke's Medical Center, Dr. Adrogue has built a reputation for providing expert care to patients facing chronic kidney disease, kidney failure, and other related conditions. A graduate of Texas Tech University Health Sciences Center in Lubbock, Dr. Adrogue has dedicated his career to the advancement of nephrology, focusing on chronic renal failure, dialysis, glomerular disease, in kidney and pancreas transplantations. I'm letting them out there today, excuse me, everyone. His specialized expertise extends to the intricate relationships between kidney health and other chronic conditions, including diabetes and hypertension, making him a sought-after physician for patients managing multiple health concerns. Dr. Adrogue's enduring commitment to improving the lives of those affected by kidney disease is evident in his decade-long practice, making him a leading figure in nephrology and in the Houston area and beyond. Without further ado, I present to you Dr. Horatio Adrogue.
Can everybody hear me okay? All right, well, I want to thank TSU for allowing me to come and speak with you guys. And in the end, save your questions. I'm not going to run away, so you'll have me as long as you can tolerate me. And then we'll be able to have a good discussion here. And I also want to thank Houston Methodist, who's my employer. I no longer work at St. Luke's or Baylor, so it's just Houston Methodist. So I want to thank them for allowing me to come on normal working hours to speak with you guys. So when I saw the topic, like the topic of what I was supposed to discuss, I wanted to break it down and make it understandable, because I think there's a lot of kind of myths and concerns about chronic kidney disease. What is it? Who gets it? How can you prevent it? And then solid organ transplantation, the same thing. And so I wanted to make this very easy for everybody, and I wanted to make it understandable. And if I say something that you didn't understand, you'll have time to ask me later. So I also want to thank Joe Sharp, who is one of the outreach coordinators from Houston Methodist. He is a partner of mine, and that's his email. And if you have any questions about the transplant process at Houston Methodist, Mr. Sharp is amazing. And I do not say that because I'm exaggerating. He is an amazing human being, and he is an asset to me personally and to Houston Methodist. So he helps do community outreach, and he helps people understand the very daunting process of going from either chronic kidney disease or end-stage kidney disease to getting a kidney transplant. So let's first talk about how we define chronic kidney disease. And these are the same definitions I use with my medical students, so you guys will walk out of here 30 minutes closer to getting your MD. So chronic kidney disease is present for 3 months or more. That's what chronic is. That's it. It's relatively arbitrary, but it usually means that it's been going on long enough to where we think it's not going to get better on its own. So that's chronic. Then kidney disease, estimated or measured kidney function of less than 60%. The mils per minute per 1.73 meter square is irrelevant. Just think of it as a percentage. So if your kidney function is less than 60%, you have chronic kidney disease. And if you have kidney function that is more than 60%, and you have either an abnormal kidney ultrasound, say you have polycystic kidney disease, or you have protein in your urine, then you have chronic kidney disease. So these are things The ultrasound, you have to go to a hospital or an imaging center, but the kidney function and the urine protein is very simple, and any primary care doctor, family medicine, internal medicine, can get that done for you. So it's very simple. So you can ask your doctor, do I have this chronic kidney disease? If they've known you for more than 3 months, they have your kidney function, they have protein. If you don't have protein and you're still wondering, then they can order a kidney ultrasound. So that's what it is. It is not anything mysterious. Now, of course, since you're all going to be, budding physicians by the end of the day, I have to put stages. You don't have to memorize these. The medical students look them up all the time. All it is stage 1 if your kidney function is normal. Stage 2 is 60 to 89 mils per minute. Stage 3 is 30 to 59. Stage 4 is 15 to 29. And stage 5 is less than 15. So there's sometimes some confusion when someone says, oh, I have stage 5 kidney function. So I have patients that have kidney function of 10%. And they insist and they swear to me that they feel fine. So they have chronic kidney disease stage 5, but they're not yet on dialysis. So when I say end-stage kidney, and if I say on dialysis, that means they're on dialysis. If I just say chronic kidney disease stage 5, your kidney function is less than 15. So what I would encourage you is when you see your doctors, don't accept the answer to say your kidneys are weak, they're not doing very well, they're a little slow, they're worse than they used to be. It's because you're getting old. Now, we do lose some kidney function as we age. That's another topic. But ask for a number. Just say, what's my number? What's my kidney number? And they'll say, well, I don't know. Well, what does the lab say? The lab will give you a percentage. They'll say 60%, 59, 82, 75. So just say, what's my kidney number? And then, do I have protein in my urine? That's it. You've just empowered yourself. So now you know whether you have CKD or not. And then you can say, well, additionally, do I need any other testing? Do I need an ultrasound, as an example? So that's how you empower yourself to know where you are in this continuum. That's important. Okay, so how many adults in the United States have chronic kidney disease? A lot. So I asked this question. None of my medical students get it right. So don't feel bad if you thought way less or way more. So last census, I think we have 330 million people approximately in the United States. Almost 10% of them. I mean, we're talking about 35 million people that have chronic kidney disease. So that's 1 out of 7. What's another interesting thing is if you look at people with diabetes, most people with diabetes know they have diabetes. 89% of people with diabetes know they have diabetes. 15% of people with chronic kidney disease know they have chronic kidney disease. So this is something that is silent. You will not feel it until your kidney function is really, really low. Less than 10% usually, sometimes 15%. So until your kidney function is in the usually CKD stage 5, you're not going to feel anything. So don't accept from a physician that says, you're doing okay. I'll let you know when it might be time for dialysis. And what I would tell you is they should say, I'll let you know when I'm going to send you to get evaluated for a kidney transplant so you never have to do dialysis. So to me, dialysis is a necessary evil for someone who comes to me too late or does not have a live donor to give them a kidney. So there's so many myths to unpack, but you do not have to do dialysis to earn your right to get a kidney transplant. You have a right as a citizen of the United States, as a Medicare recipient, if any of you guys are on Medicare, or if you have insurance. That's all. You do not need to be on dialysis to earn a kidney transplant. And I would beg you, avoid dialysis as long as you can. If you have to, you do it, but avoid it. You do not have to do it. It's important, as you guys know, I'm sure everybody in this room knows someone who has kidney trouble, has been on dialysis, and African Americans, as you guys know, are 4 times more likely than whites to need dialysis. So we're talking about chronic kidney disease stage 5, less than 15%, and I don't feel very well. I need to start dialysis. And Hispanics are twice as likely as whites. So minorities are more likely to need more help. And so that's why it's really important. And I tell this to all of my patients, both my dialysis patients, my transplant patients, and my chronic kidney disease patients. You have to remember, you have to advocate for yourself all the time. You should do it in a respectful way. Your doctor should treat you with respect, and you should do the same. But you should be, educated and just say, I would like to know this. Give me a number. Give me a game plan. Give me a roadmap to improving things. So what contributes to chronic kidney disease? We guys know what it is. So what contributes to it? Number one, diabetes. Diabetes is a complicated disease. There's type 1, there's type 2, there's type 1.5. There's diabetes that comes in kids who are younger. So any sort of diabetes mellitus, where your blood sugar is high, that's the number one cause of chronic kidney disease in the United States and worldwide. High blood pressure, they tend to go together. They tend to run in families. The number of patients I have whose mom, dad, grandparents are all on dialysis is striking. So, what I say is we can't pick our parents. You cannot change your genetics. But what you can do is change your behavior and know how your behavior will meld with your genetics to either help you get away from chronic kidney disease or run towards chronic kidney disease. Obesity, this is a difficult topic to discuss, but I talk to all of my patients in my clinic every time, both men and women. And this is what I tell them. I say, I'm not telling you that you are inferior because you weigh more than you should, but I ask them two questions. Number one, I say, when you stopped growing tall, how much did you weigh? And they laugh. Oh, it was 150. What do you weigh now? 250. Okay. So your body, you were born with two kidneys if you're lucky, and those two kidneys, they wanted you to be around 150 pounds because that's what they were designed. They were designed for that weight. And now you have added 100 extra. So let me put a backpack on you of 100 pounds, walk around the room. You're going to get tired. Kidneys do the same thing. So that's important. So it's not, and I tell them, I don't care what you look like in a bathing suit. This is not what this is about. This is about your health. So that's very important. And then they say, well, my BMI, what's this? And I said, look, you work on your weight slowly. It took you a long time to get to the weight. Now you take a long time, but start working towards that. And everybody, myself included, you have to fight against gaining weight, especially in the United States. Every time you turn on the TV or this, it's like supersize this or double size that, or buy one get one free, candy and so we're all adults. You just have to make the choices that are reasonable for you. Genetics, we've already talked about. You can't change those. Smoking and vaping. Still in this country, approximately 13% of our citizens are still smoking. I don't know why, but maybe they're stressed out, maybe they're addicted. It's complicated. But what I would say is that contributes to chronic kidney disease. Vaping contributes to chronic kidney disease. We don't know what other bad things vaping does. And I'll tell you, smoking is a very good way to block your ability to get a kidney transplant. So at Methodist, if someone is actively smoking, we tell them, go quit smoking. We'll see you back in 3 months. But if you're on dialysis, that's 3 months. I just came directly from the dialysis unit where I took care of patients, where I'm taking care of patients, to here. And I do a lot with the transplant program at Methodist, and I've traditionally helped work and fix transplant programs both at UTMB and Memorial Hermann. And one of the reasons why I still go to the dialysis unit is to remind myself and to have my trainees come with me and say, this is what we don't want. This is what we want to avoid. These are the people you're trying to help. This isn't Jane Doe, patient number 1.256. This is Jane Doe. That's her right there. She's a mom, she's a grandma. She wants to go play pinochle or bingo or whatever she wants to do. She wants to go on a cruise. So let's help her. And I think it humanizes it. Ibuprofen, this is Advil, Aleve, all of those kind of medications, not Tylenol. Tylenol tends to be okay for the kidneys, but Advil in large doses, so aspirin 81 is fine. But like if you take 325, if you've had a heart attack, it's probably okay. But if you're taking 325, 2 or 3 of them a day, or if you're taking like the bufferin packs or anything, you just read the labels. If it has ibuprofen, just say, I need to be careful with this because this is bad for my kidneys. IV contrast, this is something that if you get in a car accident and they need to do a CT scan with IV contrast, okay. But if you have something that you need evaluated, you knowing your kidney number, you can then tell the doctor that's ordering that test with IV contrast to say, just to remind you, my kidney number is this. Am I okay to get contrast? And if I have to get contrast, can you do anything to prevent it? Prevent contrast-induced kidney failure. It can be as simple as IV fluids before and a pill a couple of days before and a couple of days after. So there's prevention. And then chemotherapy and other medications that if you're unfortunate, you do what you have to do. So what can I do about chronic kidney disease? By I being everybody in the audience. Control your diabetes, control your high blood pressure, and really work on it and know that this isn't, so what I try to do is explain to my patients to the best of my ability what medication they're taking and why they're taking it. And a lot of times in order of importance, you're taking all these things. And a lot of times people themselves come in and they're on 6 different supplements. CoQ this, apple cider vinegar, like the list goes on and on and on. And I say, you know what? Why are you taking all these things? Oh, I read on the internet, Twitter told me, YouTube told me. And I said, okay, well, there's no data, there's no evidence that really helps you, but what's happening is you're filling your stomach up with all these other things, and then you may just say, oh, I can't take another pill. I'm so full of apple cider vinegar or whatever. That's an example that everybody talks about. So, and nothing against whoever manufactures it, it's just one example. And so what I tell people is, look, first understand the pills that you absolutely have to take. If you have to take insulin, you have to do that. And then everything else, ask yourself 3 times, do I need this? Why do I need this? And if you put it on yourself because your uncle or your aunt or your nephew told you to do it, maybe you don't need it. And I've had people who had liver failure and kidney failure because of these supplements. So they're not benign and they're not inexpensive. They're not free. I think the US, we spend $1.3 billion a year on supplements with unknown benefit. So anyway, okay, lose weight we talked about, or avoid gaining weight. So the youngsters, I tell, well, my son is 22, but other little cousins that he has, and I tell people, look, you know what? You're an adult. I'll just tell you, you better exercise. Why are you eating, that bad food? Why are you drinking that cola with, high fructose corn syrup? Because when you get older, if you come to 20 or 30 or 40 and you have 30 or 40 pounds, now you got to lose it. So anyway, don't smoke, never start, which is even better. Become an organ donor in life or in death. So if you yourself are fortunate that you have health, consider being a live donor if a family member needs an organ, or a deceased donor. And then one thing I'll tell you is if you can, now it's, I'm sure online, you can just click the button, I want to be an organ donor, and you get a little heart on your driver's license, I'm an organ donor. And you make that decision so your family doesn't have to. Don't put that on them. When you pass away, they have to figure out how to bury you, and they have to do this, and they're grieving, and they're shocked. So don't add one more. I've already told my 22-year-old, you don't have to make that decision for me. I've already made the decision. I'm an organ donor. After that, after you donate my organs, we can figure out the details later, I won't be here. So you can figure out the details later. But take away, so this also gives you a sense of empowerment. And don't say, oh, I'm too old, or I'm too this, or I'm too that. There's some part of you, once you die, you don't need any of you, that could help somebody. So let the people whose job it is to decide who should donate and what part of them they can donate, let them decide that. If you want to. Philosophically, if you're against it. And I still have yet to find a religion that really says you cannot donate. And if I'm wrong about that, Someone can correct me, but most religions, I'm Catholic. Catholicism does not say you cannot donate. So if you're Catholic, unless I'm a bad Catholic, I'm going to donate. All right. And I put heaven does not need your organs. So, okay. So this is a little bit about transplant statistics. So we talked about there's about 35,000 people with chronic kidney disease. I'm going to use round numbers. There's approximately 600,000 people on dialysis in the United States. And on the waiting list in the United States, there's about 90,000 people waiting for an organ. So not everybody that's on dialysis is even on the list. So you got to remember, if you're on the list, consider yourself lucky. And so make sure you take it seriously. Keep your appointments. Keep things updated. So that's very, very important. And so there's 90,000 people waiting for an organ. And in the United States, we do about 25,000 kidney transplants per year in all 290 transplant centers throughout the country. 25,000 people get an organ. These are ballpark numbers, 25,000 people. So we're still leaving a lot of people that are waiting on the list, and we're still leaving even more, 5 times more, waiting on dialysis. So it's very important. You have to be proactive about this process. There is a list you have to get on, and one of the many things that have changed, but one of the things that's important to remember is that now, any time that you've been on dialysis counts towards your waiting time for a transplant. So if you've been on dialysis 5 years, you come and you get evaluated, you went higher on the list because now you have 5 years of waiting under your belt. So that's important. So these are the numbers for a Methodist. We've been doing kidney transplants for 62 years. We did 738 total transplants, of which 287 were kidneys. So we do a fair number of kidneys. However, if you add the kidney and the pancreas, we did 291 kidneys or kidney pancreases. Our list is about 1,300 people. So it takes 6 years to turn over our list. So you got to remember, we do a lot of transplants at Methodist, but we got a lot of people on our list too. How do you jump this list? Don't even be on this list. You get a live donor transplant. You get somebody. And the other thing is, it's almost never too late to donate your organ. Even if you're older, and say you have your buddy who you're on a sewing team or pinochle or whatever, maybe you play basketball or maybe whatever you do. And you know what? You've been friends for 40 years and your kidneys are fine, their kidneys are not fine, and you want to donate to them, have a conversation. Get evaluated. Just because you're older doesn't mean you can't donate. And if your kidney function, say you're 70 years old, if your kidney function is 70% at 70, which is approximately what it should be, and you lose 1% per year, at 100, you'll still have 40%. So you can give a kidney and still have plenty of reserve for yourself. So that's the other thing to remember. You're never too old to donate either. So this is a little bit of a complicated thing, but I'll simplify it. So after 2021, what was happening is sometimes kidneys were being sent to very far away places, and by the time they would get there, they wouldn't work very well. And so what UNOS, which is the governing body that basically distributes the organs, what they said is that we're going to give preferential treatment for people who are transplant centers that are within 250 nautical miles of the donor hospital. So Memorial Hermann is a donor hospital, that's an example. There's big donor hospitals all over the country. So what's going to happen is if your transplant center is close to a donor hospital, you're going to get some kidneys first, and then if your list is exhausted and no one on your list is ready or can get a transplant, then they're going to go out from that 250 miles. So the people that really benefited from this change is if you're right in the middle of the country. You're in the middle of the country, you put a dot, and then you go 250 miles around it, and you've got a lot of land mass, and you've got a lot of hospitals and a lot of centers that you can get a kidney from. So this is where this is. Okay, so what I'm showing you here, and the shark is just a joke, but what I'm showing you here is Texas, the Texas Medical Center, so Houston Methodist. And if you go, that circle represents 250 nautical miles. Nautical miles is, as the ship sails. So what you see is, yes, we have a fair amount of land mass, but we have a lot of water, right? So there are no donor centers in that water. So what you have to remember is this kind of hurt our area. And the politics, I don't know the politics, I wasn't part of this decision. But we're always trying to increase transplants and increase efficiency of transplants. So every few years we come up with different things. So that's important to remember. So you would probably not benefit from listing at multiple hospitals in the same local allocation area. This is because any priority you may get from being at a hospital close to the donor will be much the same around the transplant hospitals that are local to each other. So what this means is, and what I tell my patients, and what I told 3 of my patients today, is look around the country and see if you have friends, neighbors or whatever, that live in a state that's far enough away that you could get to quickly, and quickly is as long as you're there within about 8 hours, sometimes 12 hours, you're fine. So you can almost do this anywhere in the country. Maybe if you live on one coast and the other might be difficult. And you can just go and say, okay, let's pick Utah as an example. Okay, how about, or Arkansas as an example. Arkansas is interesting because Little Rock is the only transplant center. So if you want a kidney transplant in Arkansas, you're gonna get it in Little Rock, which means that there's no competition. No one else is doing transplants in Arkansas except Little Rock. So if you have a friend in Little Rock, now they're gonna get flooded with applications, but if you have a friend in Little Rock as an example, you can call them and just say, I'd like to get on your list too. I live in Houston. Okay, they'll evaluate you, and if you meet their criteria, then they'll say, okay, as long as you can get here within, I don't know their criteria, but that's an example. So what I'm saying is, it doesn't help you to necessarily list both with Galveston and St. Luke's and Methodist. Well, in the Med Center, you have to choose either St. Luke's or Methodist. Biased towards Methodist, biased. So anyway, so that's important to remember. So you want to give yourself the best option. This talks about outcomes and without boring you with too many things. So the best success is with a living donor, and a living donor transplant should last you 20 or 25 years. A deceased donor still, it lasts about 10 to 12 years. So that's another reason why you want to avoid dialysis if you can, and wait as long as you can before getting a transplant. Because once you get it, the clock is ticking. So the best thing to do is prevent this. Again, we can't choose our parents, but we can not smoke, and we can not vape, and we can not allow other people to do that silly stuff around us. And we can take better care of ourselves. So that's important. And then survival outcome, this is the same thing. So at 5 years, a deceased donor transplant, about 73% of them will still be going. At 5 years, almost 85% of the living donor transplant will be going. The reason if you may hear, the half-life of a deceased donor kidney transplant is about 10 years. All that means is at 10 years, what they're telling you is about half of the people's kidney will still work, and about the other half will not work. So this again underscores the importance of living donation if you can do it, and if not, deceased donation as an option, as the second alternative. Okay, so any healthy adult can be a living donor. It's important to remember that. You can be non-related, you can be related, or you can be altruistic. The most important thing is that The donor has to be an adult, and bare minimum is 18. Most places prefer a little older, 21, because your brain develops around 21. The ladies' brain develops around 21. The men, we develop around 25. That's actually like a number. I'm not just making it up. So anyway, so you guys are a little quicker than us. And altruistic donors, these are people that, they say, I've lived a good life, I'm still healthy. Yeah, I'm going to be an organ donor when I pass away, but, I've got plenty of reserve, and I'm just going to go to a center and give a kidney to the center, and I'm going to start a swap and a chain. And that's another thing, without going to too many details. All you have to do is find someone that's willing to donate to you. They don't have to be a blood relative, as long as they have an emotional attachment to you. Or if they want to be anonymous, that's fine. And then if their blood type doesn't match, it doesn't matter. Because if the donor and the recipient are both willing to be in the swap, we can find someone else whose donor blood type also doesn't match, and we can do a swap for you. So the most important thing is, it's the job of the transplant center to figure out if you are a candidate, and if you're on dialysis, even if you have CKD, what I would say is, it is your right to get evaluated. It does not mean you're guaranteed to get a transplant, but it is your right to get evaluated. Don't let anybody say, you're too old, you're too this, you're too that, you're too tall, you're too short. No, it's my right to get evaluated. Maybe I won't pass, but I'm going to get evaluated. Donor, same thing. If you want to donate, fill out, there's a Breeze application on the Methodist website. Get evaluated. And if you can donate, great. If you can't, the other thing is, if you're a donor, the insurance of the recipient pays for the evaluation. So you're not out of pocket. You're not going in and paying for the doctor visit and paying for the labs and paying for the ultrasound and this and that. And we've had a lot of people who come forward very selflessly and altruistically and say, I want to donate to my daughter. And then they're discovered that they have something. I didn't know I had breast cancer. I didn't know I had colon cancer. But now, because I was trying to do something good for somebody, I'm doing well because of it. So there's a lot of benefits to even an evaluation of being a live donor, to you personally, and even if you don't pass, imagine the connection you've made with your recipient. You stepped up, we're evaluated, the transplant program said you couldn't donate, but you know what, you have a friend for life, or maybe you already had a friend for life. Okay, so living donor statistics, almost 250,000 people have donated, and about 1.5 million people worldwide. 6,000 people donate every year, this is kidneys. 99% of kidney donors say they would do it again. And 99% of these never develop kidney problems or after donation. So is that by luck? No, it's by design. We will evaluate things very, very well. So some donor myths and facts. Myths, kidney donors will have to take long-term medications. You don't have to take anything. Long-term medications are not needed. Kidney donor can no longer exercise. That is not true. Regular activities, people exercise within 4 to 6 weeks, so not a problem. Female kidney donors shouldn't become pregnant after donation. Again, not true. You should wait 3 to 6 months. You must have a strict diet. There's no dietary restrictions, but just take care of yourself. It goes, if you don't want to have chronic kidney disease, don't gain weight and don't develop high blood pressure and diabetes. So any questions, and I want to ask the first question, have you ever considered being an organ donor? You don't have to answer it. Answer it to yourself, answer it to your family, or don't answer it at all. So that's it. I may be over a few minutes, I'm sorry. But I think we're going to keep moving, and I thank you very much for your time.
In the audience, any questions? We only have a couple questions online.
Yes, let me just grab some. Hold on, let's put it on the microphone because we're recording so everybody can hear. Thank you so much.
Sign up to be a donor if they still take organs when signing up for it.
So if I'm No, ma'am. So if you do not consent to be an organ donor in the United States, there is not presumed consent. So if you die in Spain, Even if you're a US citizen and someone doesn't say she didn't want to donate or you're not there to, they will take your organs because that is a presumed consent country. But the United States, no. You have to be an organ donor. It has to be on your driver's license. You have to have a little heart. And if you don't consent, it would be assault to take your organs. So no, ma'am.
If one of your family members agrees on it, can that happen?
So yes, that is correct. So if your surrogate, who you said, this is my medical power of attorney, and they said, yes, she wanted to donate, then absolutely, yes. Yes, ma'am, thank you.
Good morning. My question is, how do we get in contact with you? I have stage 3 CKD, and a lot of things that you were saying as far as being proactive, I've had to do, but what I want to know, how do I get in contact with you?
I brought my cards, so I brought, I don't know, several of them, so I'll pass them out, and if you don't get one, just take a picture of it, and you know, I have clinic in the med center, so if you live here, it's going to be a drive. But I live, you know, I work in the med center and be happy to see anybody and discuss their chronic kidney disease and help risk stratify and help prevent you from ever needing dialysis and maybe even ever needing a kidney transplant too. Thank you.
What do you do to like prevent from going on dialysis? What's the plan?
So this is where you have to be under the care of a doctor and you have to, you know, individualize your plan. So what you have to do is you have to, whoever this person is, you have to say, okay, are you at ideal BMI? Is your blood pressure ideally controlled? If you have diabetes, is that ideally controlled? Are you taking medications that are working against you? And then the protein in the urine is very, very important because there's a lot of new medications that will tell us, that will help reduce the protein in the urine, which helps slow down the chronic kidney disease. The other thing that is gaining a lot of traction, and actually is part of my standard of care, is genetic testing. We can do genetic testing. It used to be really expensive. It's gotten very affordable, and most companies will bill your insurance, and whatever the insurance pays is what they take, and they won't bill you more. And the genetic testing is a swab of your cheek. So I can do it. You come into my office, and I can do it in the office. Because a lot of people, probably about 15% of people come to the attention of a nephrologist, and there's no obvious reason they have chronic kidney disease. They're thin, they don't smoke, they don't have high blood pressure, they don't have diabetes. Like, we're just scratching our heads. So what we did, so there's a non-invasive way is to do a genetic test. You swab the cheek, you send it off, 6 weeks later you get a result. If they have, and this is where you have to do an individual case, if they have a lot of protein in the urine, it's telling us that the filters are damaged. So then the next step is, if you have a lot of protein in your urine, the next step is going to be a kidney biopsy. So again, this is an invasive thing. This is an individualized thing, and you have to be off of aspirin, and there's a lot. So there you have to be under the care. So I can't give a generic thing other than what I've said. Do everything that I've said, and you're already well on your way to taking care of yourself. I think a lot of doctors, because we feel we can't tell people what to do. I'm not telling anybody what to do. I'm just telling you what will help your kidneys. You can do it, you can not do it. You know, weight loss, smoking cessation, don't vape. Just because you have a little bit of knee pain, take some Tylenol. If that doesn't help, then get rehab. And if that doesn't help, figure out why you have knee pain instead of keep taking medications. Or if every time I go and play 4 hours of football, I have knee pain, stop playing so much football. I mean, unless you're a professional, right? So, I mean, there's kind of practical things. But thank you very much. Great question. Yes, sir. Yes, ma'am. Yes, yeah, let's just make sure that they get the mic.
Hi, good morning. I'm Joanna Dominguez.
morning.
Is there a special diet that someone should follow after being diagnosed with chronic kidney disease?
So that's a great question, and that is a whole other talk, and that's a whole other No, it is, and that's a whole other group. There's specialists, there's renal dietitians whose job it is to help you through this. And actually, the National Kidney Foundation's website, NKF is over there, the National Kidney Foundation website is awesome, nkf.org. I don't think you've changed it. So that's awesome. You go there, and once you've asked your doctor, what's my stage of chronic kidney disease? Then you go in there, and then it'll say recommendations by stage. Go in there, and then at the bottom, you have to hunt a little bit. There are renal dietitians. So you can, contact a renal dietitian and just say, I have this stage of chronic kidney disease. What should I be doing? And they help you. It's a really long topic, and you have to see what they're eating. You have to do a food diary. So it's not something I can answer in 2 seconds. But I can give you the information to go to the National Kidney Foundation website, nkf.org, and look in there. There's so much information. And diet is very, very important. But in general, anything that's processed, anything that you don't cook yourself, and it just look at the ingredients. If there's like 5 or more ingredients, and if you can't understand if you need like a chemical degree to understand what you're reading, you shouldn't eat it. I mean, you shouldn't. So what people say, what should I drink? Drink only if you're thirsty, and that's another thing. People say, I have to drink so much water. Unless you have kidney stones, drink if you're thirsty. Don't drink if you're not thirsty. And what's the best thing? Water, coffee if you like it, tea if you like it, but don't add milk. Well, you can have a little bit of milk, but like if you had sugar and then you have sweet tea and then you have 8 glasses of sweet tea, then you're wondering, why can't I lose weight? It's your 8 glasses of sweet tea. So, and just do a food diary. It's very simple. You do a food diary and you're already halfway there, or part of the way there.
Alrighty, guys. I hope you guys are enjoying this session so far. Up next is our panel discussion. I'm going to go ahead and introduce our 3 amazing panelists, starting with Ms. Alexis Cornell. Ms. Alexis Cornell is a resilient kidney transplant recipient and passionate advocate for kidney health. Diagnosed with fibrillary glomerulonephritis in 2010, she began dialysis in 2011, and after enduring significant challenges, received a life-saving kidney transplant on July 17, 2012. Now thriving nearly 13 years post-transplant, she dedicates her life to advocacy and education. Ms. Cornell has worked extensively with the National Kidney Foundation, the Apollo Study, and other organizations advocating for kidney patients and sharing her story in interviews, podcasts, and national events. In 2019, she launched Alexis Cornell Speaks to raise awareness about the importance of post-transplant wellness, particularly in the African American community. She also published Journal Your Journey to Health in 2021, offering guidance and inspiration to others navigating health challenges. Through her advocacy, public speaking, and partnerships with fitness professionals, Ms. Cornell continues to empower others with her journey, proving that her second chance at life has a profound purpose. Up next is Ms. Sharon Copeland. Sharon Copeland has been a social worker for over 23 years. She spent her early career in mental health counseling children, family, and adults. She took a break from her profession to raise her 2 children. In 2016, Sharon joined the Living Bank and serves as an independent living donor advocate. Sharon enjoys her vacation and can recount many highlights during her time as an independent donor advocate. One memorable moment was when she interviewed a donor at their 1-year postoperative appointment. The donor expressed how much the donation changed their life, that it was the best thing that had ever happened for them. For Sharon, this vividly illustrated the life-changing power of transplants, both for the recipients and the living donor. Alrighty, Ms. Sharon Copeland. And last but definitely not least, Mr. Virgil Elkins. Virgil Elkins, a proud military brat from Tampa, Florida, began his health journey at the age of 12, unaware that a routine sports physical would uncover a life-altering condition. Diagnosed with FSGS, a rare kidney disorder, Virgil faced a series of medical challenges, including multiple biopsies, medications, and ultimately dialysis. At 22, while a college student, he found himself in a hospital room grappling with depression after learning that he would need surgery and immediate dialysis. Despite the overwhelming obstacles, Virgil adapted to his new reality, receiving 2 kidney transplants. Unfortunately, his first transplant failed due to the BK virus, and the second was rejected after 2.5 years. His journey took another drastic turn when he suffered a life-threatening surgery complication requiring a blood transfusion after losing 3 to 4 pints of blood. Now, 12 years into dialysis and still awaiting a transplant due to high PRA levels, Virgil continues to inspire those around him. His resilience shines through his active community service, fraternity involvement, and hope for the future, particularly as he looks forward to marrying his fiancée. Virgil's story is one of strength, perseverance, and the relentless pursuit of life. No matter the challenges, he quotes, "God did not wake me up to give up."
All right, so can you guys hear me okay? All right, so we've prepared some questions, and how about let's start with how do you navigate the emotional and psychological challenges faced by potential living donors during the decision-making process?
So I primarily work with donors. I work with potential donors that are interested in possibly donating, and as you know, it's a tough decision. It can be. It can be a scary decision. Some donors know right away they want to do that. Others, they need to have a little time to think about it. So I really listen to them. I also validate their concerns if they have any, and I also encourage them to take time to really think about anything they could be struggling with for those who may have a harder time making that decision. And that seems to help. I think they usually come to that realization at some point during the process too.
Thank you very much. For Mr. Elkins, how was receiving a kidney transplant change your perspective on life and your relationship with others?
That's a good question. So really, it changed my perspective in really understanding my health, knowing that I wasn't immune to, any type of illnesses and things of that nature, knowing that it's important to visit the doctors when they're talking to you initially, because there's a warning somewhere, there's a warning. And when they're talking to you about preventive measures and care, to really take heed to it. And so now I'm sharing it with my friends, my family members. I'm proactive versus reactive. That's the biggest thing. I'm researching medications. I'm on Dr. Google all the time, and I shouldn't use it, but Dr. Google helps me ask questions and helps me build relationships with my doctor. And then I've developed this mindset that states that if the doctor sees that I care, maybe they'll care as well and be a little bit more transparent in my care and as well as aggressive with my care as well.
Thank you. For Ms. Cannell, what was the most difficult part of your CKD journey, dialysis, and how have you found strength to continue?
The most difficult part was just, I feel like I was in denial initially. I actually felt like I was listening to you and you were kind of telling my story, especially at the end. It was found by accident. I had some protein in my urine, but I stayed in denial pretty much the entire time, and it wasn't until I was told I may have to go on dialysis, and I was still kind of in denial. My nephrologist was giving me my options, and I ended up what they call crashing into dialysis, where I passed out. I had to go to the hospital. They ended up keeping me, and I had to go on dialysis right away. So I ended up having to do peritoneal dialysis, which was what my doctor recommended. It ended up being the best for me. But it was a very difficult process. It was a lot to learn. But I had a great support system, so that really helped me a lot. So if you have a great support system, that really can help you get through a lot of the challenges that you deal with, and the changes in your body, different things like that. It's a lot to deal with, but you just have to stay positive about it.
Thank you very much. Okay, so I'll take one of the questions. We'll do a round robin. So what barriers do you see in encouraging individuals to become living donors, and how can we address these barriers on a systematic level? So I think the first thing is that you have to start at the micro level. You have to start at the family unit level. And it starts with the person who has chronic kidney disease and then eventually ends up needing a kidney transplant. They first and foremost have to be open to the idea of a living donor. A lot of times what I find is the patients themselves are the biggest barrier, and it takes a while to figure that out. So I always start with that. I say, are you open to getting a living donor if your family members are? And usually it's like, no, I don't think so. I haven't thought about it. So then, I see my patients every 3 months or so. I say, okay, I would encourage you to talk to them, but we'll have this discussion again. And then eventually, once you kind of win them over, or if they come with a family member, you can, with their permission, you can talk to their family member and say, this is coming, and if you guys have possible people that will donate a kidney, you really should be proactive about this. So I think the first thing is the patient in front of me, or if you are the patient yourself, you need to be okay with someone that you love, a family member or a friend, to donate a kidney. That's one big barrier. And then the other barriers is talking to everybody in the family in an open way, and you just have to, try to make sure things match and things align. At Methodist, I don't know, it was like 2 or 3 years ago, we did one of the oldest donor and recipient pair. I don't remember their exact ages, but they were in their high 70s. I think the recipient was 79, the donor was 84. And they were exactly what I was describing. They were neighbors for a long time, and then the older neighbor who was healthy noticed that he wasn't seeing his younger neighbor, and then they talked, and she said, yeah, I've been going to dialysis. And he said, well, why didn't you tell me anything? Again, the patient themselves thought, well, I've lived a good life. I'm not going to bother anybody. And then the donor said, well, look, I'm not going to live forever either. And if I can get you off dialysis and we can continue to hang out for the next 5 years, you're doing me a favor, I'm doing you a favor. It's a win-win. So I think that's everything in life, especially in medicine, is about communication and is about establishing trust. So you really have to try to trust your doctor, and I tell people, if you don't feel you trust me as your doctor, I would encourage you, find someone that you do. That's okay. There's only about 9,000 nephrologists in the entire United States. 9,000 of us for the 36 million people with CKD and all the other numbers. So find one that you like, that's reasonable with you, stick with that person, and have them guide you. So I think that's important. So first, the patient themselves need to not be a barrier. And then their family needs to get involved. And then from there, and the process of getting a transplant is complicated and is long. So I tell people, this is a marathon, it's not a sprint. And all the things we tell you, take notes. Because the coordinators, they'll call you to kind of help nudge you, but at the end of the day, you're the one that needs to schedule your dental appointment. You have to set up your colonoscopy. You have to go see the gynecologist. You have to go see the doctor, the cardiologist who needs to clear you, because otherwise you won't get a transplant. So the patient themselves has to be the captain of the ship, and everybody else. And if the patient can't be the captain, then a loved one can be the co-captain or whatever. But that's the important thing. So I think those are barriers. And I would be very interested, whether it's now or from the audience, what barriers do you guys see in your community? Because if you guys see barriers that's in your community that we as physicians are doing wrong, if we're not explaining things well, if we're not approaching it right, then educate us, because we want to help you. And sometimes we just shrug our shoulders and say, I don't know why every time I talk to this family, they don't want to donate. Is it okay for me to turn the question to the audience? So if someone wants, I'll give you my, I'll run down there. Here. Does anyone want to? There you go.
I hope I'm understanding your question right, but I think of areas, especially like in the Hispanic community, the Latino community, immigrant community, they just see it as a taboo to, to be a person that donates part of your living body, something to somebody else. They just think like maybe you're gonna get sick afterwards or something that's gonna happen to you, some health issues are gonna happen to you. They just don't see it as a good thing for the person that's gonna donate. And that's something that we need to like educate our community on that and let them know, hey, this is right, this is gonna help you, this is gonna help everybody. And I just think that that's something that we need to speak about more, especially in our community.
Anyone else? Anyone else have insight or want to share? Everybody's kind of shy. Yes, sir.
So, for instance, if you have to go on dialysis, what's the life expectancy of a person that goes on dialysis?
So the mortality rate can be up to 20% per year. It's not necessarily cumulative. It doesn't mean that in 5 years you're going to pass away. But in any given year, you have about a 20% chance of dying if you're on dialysis. Whether you have an infection from a catheter, or from a fistula, or you have a procedure that doesn't go well, or you have a reaction, or your blood pressure drops too much, or you have a heart attack. So yeah, the mortality rate of being on dialysis is similar to some cancers.
No, because I see more people are on dialysis than actually waiting to get the actual transplant.
Right. And part of that is because people think that I'm on dialysis, someone will tell me what to do. Someone will come here and tell me, hey, get on the list. Or sometimes they come to Methodist and they say, they come to Methodist and they say, they have one visit with me, again, marathon, not a sprint, and they go, so I'm on the list now? No, we just had a 30-minute conversation. You're not on the list now. This is the beginning. This is the first of many steps. And then sometimes people they say, well, this is not worth it. I don't want to do it. It's not worth my time. Okay, then you're going to live much less. So if you look at the numbers, if you're young, if you're in your 30s and you're on dialysis versus getting a kidney transplant, you could add 20 or 25 years to your life. If you're older, say you're over 70, you might add 5 years to your life. But 5 years, how many birthdays is that? How many, cups of coffee with your best friend? How many trips to the beach or wherever? So it all depends. So very, very importantly, this is not a passive process. You have to own this. You have to own it. I own my own care. I own my own life. I get up at 5, I go running, and I do what I have to do. I get showered, I work, I come home. So you have to own it. It's your life. There are 8 billion people on the planet now. So you have to say, hey, I'm one of those people, and what do I do next? Okay, I'm doing this. Okay, who do I talk to? I tell people, if you haven't heard from your coordinator in a week, call them. Hey, haven't heard from you. What's my next step? Oh, I'm very glad you called. Did you get the, I didn't get the email. Did you get I didn't get that either. Okay, you need to see the dentist, or just say, what's my list? You need to see the dentist, you need a mammogram, you need a colonoscopy, you need this, you need that. So that's what you need to do. You need to be proactive. So, and to the answer about taboo, all of this is really based on fear, I think. And, taboo, like someone says, oh, we just don't do that. Who's we? Who's they? Oh, they told me. Who's they? Am I they? Are you they? Who's they? So you just need to specify, and you need to know your audience. Oh, in our family, we just don't donate. So you would prefer to have your mom or your brother on dialysis just because you don't do that? That's your personal decision. But as a group of people, as Hispanics or African Americans, or I forgive me, but I have to push back on that, and I have to say, that's not, because the people that are suffering are the same people that are in your family. I'm not saying you have to be a live donor for someone you don't know. I don't know that person. Maybe they're not a good person. Why should I give them? But my brother, he's a good person. My mom, she's a good person. My dad, my uncle, my niece, my nephew. So at some point, again, I always start at the sand level. The little sand is the person. And then, the universe is so much bigger. But we're the little grains of sand. And so you're that person. Then you need to talk to the grains of sand around you. Hey, guys, I need help. Well, why don't, it's taboo. Why is it taboo? Oh, I don't know. Joe's told me. Let's go talk to Joe. Hey, Joe, why is it taboo? Oh, I don't know. Mary told me. Mary, why is it taboo? And now you've talked to 8 people, all of whom are telling you it's taboo, but based on nothing. Based on this is what we do. Now, so I would say if someone has a deep religious thing but it's not Catholic, you cannot be Catholic and say you're not allowed to donate. That's not true. So you can't say, well, Jesus didn't want me to donate. No, I think he probably would. He died for us, so I don't know. Anyway, so my point is, you guys, if you guys push back, first, the patient themselves needs to be okay with it. And then everybody around them. And then you guys start pushing back on your loved ones and say, why is it that we don't donate? Why is it that we are not in clinical trials? And yes, historically, there's been horrible things that have been done to people of minority status in clinical trials. Absolutely. But that's not 2025. There's so many protections. And the other thing to remember is that you develop a vicious cycle. So I, as someone from Argentina, I don't want to be in that clinical trial. But if I get cancer, I want that chemotherapy. Oh, but you were never studied in that clinical trial, so I don't know if it's going to work for you. So I, of Hispanic or African American descent, I don't want to be in the clinical trial. But if you and nobody wants to be in a clinical trial, then all of a sudden, every time, so for example, someone says, why is it that when you quote me data on live donors, most of the data is in whites. The biggest numbers are from Minnesota. I trained in Minnesota. It's because more whites donate than African Americans and Hispanics. So they donate so I can see how they did because they donated. And so, if no one ever donates, then I can't tell you how you're going to do. I can tell how people in general do, but I may not be able to tell you specifically. And if the people have family history of chronic kidney disease, so you as a donor can say, I would like to have genetic testing. I would like to know if I'm going to get chronic kidney disease. Does that make sense? So every problem has a solution, and every barrier you can say, yeah, that doesn't make sense. Yeah, that's not real either. So that's what you have to do. But you guys, you have to advocate for yourself. I advocate for my patients, but I'm one person. I can only advocate for so many people, and every individual has to advocate for themselves. Yes, ma'am.
Okay, so I'm going to speak from 2 perspectives. One, as a Black woman in the community, and the other as a clinical research coordinator at Houston Methodist that talks to patients about this all the time. So first, I want to say that dialysis in our community feels familiar. It's something that people, they're like, oh yeah, my uncle's on dialysis, my aunt's on dialysis. That's something that they're used to hearing. But when it comes to transplant, having a major surgery, those sorts of things, it's like, I don't want to go under the knife. I don't want to, they're going to put me to sleep. What if I don't wake up? Things like that. So I think that contributes to the number of people who are okay with dialysis versus transplant. And so as an educator, as a coordinator, trying to educate people on the benefits of, preemptive donation and living donation and being a recipient before you need dialysis is a challenge. So the other side of things, as a person who speaks to people with CKD risk factors who may not know, it's one of those things where it's like, you mentioned denial. So first there's this, I feel fine. yeah, I have to take a high blood pressure medicine, but it's not a big deal. And then I've had diabetes, my mom has diabetes, it runs in our family. But like not knowing that those are risk factors for CKD, so like the not knowing is the one. And then once you are told, it's like, what do I do? I feel fine. And I want to say from the other perspective, as a provider, we hear a lot that, like you said early in your talk, well, your kidneys they're a little weaker than before. So people don't know what that means.
Right. It doesn't
You know
mean
what
anything.
I mean? Like,
It means
and they
nothing.
don't know to ask for numbers. And I'm looking at, my CBC, my results from the lab. I'm looking at my GFR because I know that. But that's not something people draw attention to, or your provider does, unless it gets bad and you don't have time to fix it. So I think I just want to highlight that part of your talk to say, when you go to the doctor and you have your blood work done, ask about it. Don't wait for them to say, this is a problem. Ask them how your kidneys are. How are my kidneys doing? Can you give me a number? What does that mean? Don't be afraid to ask what something means, because sometimes you go in there, it's 5 minutes. You don't have time to get it all out. And if you're not a person who can speak and remember, write it down. Go with your list of questions. Ask, I have questions, I'm concerned, I'm feeling this way. I have this strange itching all the time. That's a symptom. You may not even know it. So just feel empowered to own your health, like you said, and make sure that you are the person who is in charge of your body, because you have that right.
No, thank you very much. No, that's good. Thank you.
My question is about the beer part. Is it bad for you to drink beer before you find out that you have kidney problems, or is it bad to drink beer when you have kidney problems?
Okay, so beer is essentially alcohol and water. So beer in and of itself is not harmful to the kidneys in moderation. So
The reason I'm asking the question is because when my nephew passed away with heart problems, and he had donated the parts on the back of his driver's license.
Yes, ma'am.
And both his kidneys were used, and he would drink at least 5 beers a day.
So beer, alcohol is damaging to the liver, not the kidneys.
They used his liver, they used his kidneys, they used his lungs, just about his eyes. I mean, we got all kinds of thank yous from people all over the world.
I mean, I'll tell you, maybe he drank a little too much, but at the end of his life, he made an altruistic decision. Mm-hmm. So what I would do is remember him as a kind human being who liked to drink a little too much. Okay. But you know what? But
that's why I was asking, because I knew he loved his beer.
That's so what I'll tell you is, and beer is it's alcohol and it's also calories. So you start doing the food diary, and I don't drink, so I don't even say it's 100 calories per beer, maybe, I don't know, but it's 500 calories if you drink 5 a day, and then you eat this and you eat that. So it's calories and it's alcohol. So it's bad for the liver, not bad for the kidneys, but more than 1 or 2 drinks a week, I think, is probably not healthy. Oh. If you want to drink every day, that's between you and your body. But and also, if you drink too much, sometimes you make bad decisions. And if you drive, then you hurt other people. So that's not right. But thank you for sharing. And you can, when you pray and talk to him, thank him.
Okay.
I just want to make one quick comment. I really appreciate all the fact that you said dialysis feels familiar. I would also say, you know what? And you said another interesting thing. You said, I don't want to go under the knife. Now, if you're on dialysis, you should have, if you're saying, I'm not going to get a transplant because I'm not going to go under the knife. I'm going to be on dialysis the rest of my life, however short and unpleasant that is. You're going to get a fistula. So you're going to go under the knife. They're going to have to open up your arm, connect your artery and your vein. So you're going under the knife. So you may not recover from that. So why not skip the dialysis part altogether if you can? Start with the younger generations, prevent. If you know your genetics, if you don't know genetics, go to your doctor and say, hey, you know what? If you have chronic kidney disease, I'd like to know why I have it. Oh, we don't do that here. Fine, okay, I'll give you my card. Come see me, we'll do a genetic test and I'll tell you, you have nothing or you have something. Then you can go back to your kids and your grandkids and say, hey guys, we have this in the family, whether we like it or not. So you know what? You guys take yours. Oh, I'm 22, I'm bulletproof. Well, none of us are bulletproof at any age. So it's important for them to know. And again, it's about education. And then you can, what I would say is, I would hope that by the time I pass away, which I'm hoping will be over 100, we can start saying that people shouldn't be familiar with needing dialysis anymore. You should be familiar with healthy diet, familiar with not eating. And the stuff that we eat that's bad for us is really expensive. You know, even though they sometimes make it on sale because it's like, you know, a bottle of pop or whatever. But so just make better choices and make better choices in front of your kids and your grandkids and tell them, no, you know what? We're not going to do that. We're going to do this instead. And just because you've had generations of people on dialysis does not mean you should accept that the future generations should also be on dialysis. I would say you and the future generations should not think it's taboo to donate, because it's not taboo. Anyway, do we want to do some other questions, or are there other questions from the audience? Yeah, okay. Yeah.
Really just include knowing that dialysis is part of my life. You know, I go to work after work, you know, everything that I have to do is surrounded by dialysis. So I just make sure my schedule aligns with the dialysis schedule. The foods that I eat won't harm me, like, you know, won't give me a headache, swelling, or, you know, stop me from doing regular activities. You know, won't have me calling into work, won't have me just laid out somewhere. And really, I've been doing it for 12 years. And so I've learned, like, really just how to just enjoy life around it. You know, it's almost, I hate to say it, but it's almost like I'm a little homeboy. You know, got dialysis is coming along with me. If I travel somewhere, I have to make sure my treatments are set up where they need to be, my schedule set up. And again, the diet and having a support group as well. So managing my time is really, really easy as long as I know that I have to do a dialysis, as you stated before, just owning it as it's a part of my life until, you know, get that transplant.
But also, thank you for sharing that, but also, Virgil, but you didn't accept that as dialysis, this is the only way. You went through the transplant process yourself twice, right? So that's, I think, important to underscore, that, you know, you've accepted it as a part of your journey. Now, hopefully, you will be able to get another transplant. But you know, and your disease is a very aggressive disease. And so, again, through no fault of your own, did the transplants fail. So that's important to remember, that you sought care, you got care, you had a disease that's very aggressive, and there are some diseases that are very aggressive. And so it's important for people to understand that. That doesn't mean you shouldn't evaluate yourself for a transplant, but you just need to understand what potentially could happen. So thank you very much, but that's really, really important to know. Let's see, how do you ensure that both donors and recipients receive equitable support, particularly in underserved communities?
So, it's been great hearing from all of you and things that you've talked about, even within some of your own communities. I think for the recipient and for the donor, it's also helpful knowing they also have their own team of people that they're working with. whether it's the doctors or at the transplant clinics. I think that also helps them many times know they have people there for them that they can talk to or that they can call. If it's someone in their family, that's great, but if they need someone outside of that, a professional, there are people there that can help answer questions. And a lot of it's just knowing, like you were saying too, how to help maybe get people involved in that, to know there are people out there that can help.
Thank you. Alexis, how has being a dialysis patient shaped your views on the importance of kidney health, advocacy, and education?
So I did dialysis for just under a year before I was able to get my transplant. So it's changed my life in a way where, once you are in that position where you feel vulnerable when you're going through a dialysis, and like I say, I was very fortunate that I didn't have to do it very long, but going through that process and then having your transplant, it really makes you look at life differently. It makes me, for me personally, I'm a very touchy-feely, lovey kind of person. So, but I love on the people around me more. And it was also very important for me to share my story, to share everything that I've been through, so that, if I could just help one person to either not have to go through what I went through or to help them to be able to get through some of the things that I went through, because I've experienced a lot of it. I did have a very aggressive disease and my kidneys failed very quickly. And I was, told to go to a urologist. I did that, but by the time they sent me to a nephrologist, I didn't go. And I didn't go because I felt great. I was working out, I was modeling full-time, I was working full-time, I had a career that I loved, I was doing all of these wonderful things, I was living what they call your best life. I didn't feel sick. And so I never went to the nephrologist until one day I experienced horrible back pain, ended up in the emergency room. They thought it was my back, and it turned out that it was my kidneys. By that point, I had lost half my kidney function. So it goes back to I had a great team of doctors who really helped me extensively. They made sure that not only did I stay on top of my health care, but they stayed on top of it as well. And so we were able to, eventually get a diagnosis and move me along the process. But it just going through all of that just helps me want to be able to help people more. I had a 25-year career in healthcare, and I did that because I love helping people. And I just continue that on in a different light by, going out and speaking and sharing and, being a resource for other people, for writing the book, the books that I write. So it just helps me to make sure that I'm a better person and take care of myself so that I'm in a great position to be able to help others.
And then, Virgil, what challenges did you face during the post-transplant recovery period, and what support systems helped you the most?
Challenges would really be mental depression, being young and not being able to participate in activities, athletic competitions as my friends, engaging in activities that they would, or just being free to travel. That was the biggest thing. I believe even now I haven't traveled internationally just because insurance won't pay for, dialysis overseas. If I want to take a cruise or go somewhere, insurance won't necessarily pay for it. So being restricted to certain areas and activities, but also having the friends meet me where I'm at. They'll come and sit in the center with me, or they'll come and visit me after treatment, or they'll come and see me if I'm being hospitalized, come and hang out with me. I moved here about 8 years ago by myself, all my family there in Florida, and just having that support system now, was really good, or is really good. My mother is always worried I'm out here by myself, and my fraternity brothers or my friends are just, surround me with love and support. So that's helped me, throughout this entire experience.
Thank you. Sharon, any final comments?
No, I don't think so.
No. Virgil, any final comments?
Be proactive in your care, in your health. Extremely important. It's one thing that I will say about dialysis, it does take a lot of your time. It's 4 hours a day, or 4 hours per treatment, and it's 3 days a week. And again, it is like a second job. So I go to work from like 7 to 4, then from 4:30 till about 9 o'clock, I'm in treatment, traveling home, and have to do it all over again. So if you can be proactive in your health, watch your food intake, your dieting, the way you eat, God willing, you won't ever have to have this experience.
And Alexis, any final comments?
Yes, as Virgil just said, please be proactive, know your numbers, develop relationships with your doctors. You know, they're there to help you. If you've been through the transplant process and you have a coordinator, develop relationships with them. I know for me, I call my transplant coordinator all the time, especially when you see stuff on social media and it's like, oh, I think I want to try that. And then I'll send it to her and say, hey, is this okay? She'll say yes or no. So just develop those relationships, stay active. I do meal prep. I try not to eat fast food at all. I try not to eat processed foods. I am a foodie. I do like to go out to restaurants. Be careful how your food is prepared. Make sure that your foods are cooked very well. But just be proactive and try to stay on top of your health. That's extremely important. No one knows your body the way that you do, and listen to your body.
And I'll just have 10 seconds, quick comment. As part of being proactive and taking care of yourself, come to see your doctor face-to-face. I know COVID moved us towards AI-driven, you know, you can see people virtually, but I'll tell you, it's difficult as a doctor to take care of somebody that you see once every 3 or 6 months. You only see them on the computer screen. They're distracted. The computer screen is glitchy. You hear half of what they say. They don't hear you. I've had patients have their doctor's appointments in their cars. They're going through getting fast food. They're they're checking out of their grocery store. And I understand we're all busy, but at the end of the day, you guys are the ones that suffer if we don't have the information to help you. So, I mean, I just say, okay, I didn't hear you. No, oh, wait, it's okay, we'll talk about it another. Okay, all right, well, thank you very much. And then we can only do what we can do. Physically seeing you, we can say, hey, you've gained weight, but it's fluid weight. We need to adjust your meds. Hey, something's wrong. Or hey, you kind of smell like smoke. Well, you know, my cousin, he keeps, well, that's not good. Tell your cousin to come talk to me. So there's a lot of things that we can detect physically seeing you. And, you know, AI is revolutionizing medicine in a good way, doing genetic testing, making things more efficient. And I think we need to embrace it. But we also don't want to take the human out of medicine. And if you guys, as the patients, take yourself out of that equation and you're just a screen, it does make it more challenging for doctors. It's not impossible, but it's harder. And at the end of the day, we're all being asked to see more and more patients quicker. And so if I see you, I can connect with you very quickly. If I spend 2 or 3 times the amount of time trying to struggle with the AV and I don't really feel I connected with you, you also won't feel you connected with me. And then you may not come back the next time. And then you crash into dialysis or, you know, forget to take your meds because you didn't understand why it was so important. But thank you very much. Please be an organ donor.
I want to bring up the director of the Community Engagement Program, Dr. Veronica Adrogue, who will go over the Texas Chronic Kidney Disease Task Force.
Awesome. Thank you very much, Virgil. Please help me to appreciate our very speaker and the panelists. That was such an amazing session. A lot of knowledge, a lot of heartfelt information. And to you all, the audience, wow, a lot of curiosity in this room. Please give yourself a round of applause, guys. This is very, very amazing. Thank you, thank you. I'll be really brief, just want to share 1 or 2 information regarding what we are also doing on the side of research, right? Dr. Adrogue shared a lot of information regarding, the data, so I'm going to skip that part, but the question is from a research standpoint, what are we doing to advance health regarding chronic kidney disease? So this information, saying that here in Texas, we already know the numbers, but what then are we doing? I have the privilege to work alongside my partner and my friend, Amy Waterman from Houston Methodist Hospital. She's not able to join us here today, but she has representative from our lab. We have Imori and Myra, both of them them are in the audience. Amy and myself have the privilege to lead an NIH-funded grant under MIED, where we are looking at complications regarding chronic kidney disease. During the course of today's conversation, I had a lot of curiosity in the room. Dr. Adrogue stirred us up, right, to ask questions. What we will be doing as part of the community engagement for this project is for us to have focus group sessions. Right, Dr. Adrogue asked us, right, okay, what are those barriers to transplant? What are those barriers to, awareness about chronic kidney diseases? What are the fears? What are the concerns that we have? So you guys already signed in, when you came. We are in the process of receiving IRB approval. Once we have our IRB approval, right, Imori? We're working on that. Once we have our IRB approval, we will be conducting focus group sessions. And we would like you guys to please be a part of that session. Because as part of this session, we'll be asking specific questions. We want to know why. How can we address the fear? How can we address the concern? What language do you want us to use? How can we bridge the barrier? I'm a pharmacist by training. So how can we bridge the barrier regarding medications in chronic kidney disease, pre-transplant, post-transplant, and everything in between? So please stay in touch with us. More information will be coming regarding this particular project. Thank you very much. I will turn it back to you, Virgil. And please help me to appreciate Virgil. Virgil is our project manager, and with all his history that he shared, me being his direct supervisor, Virgil has done amazing. Work ethics on point, and I'm very grateful for you, Virgil. Thank you very much.
All right, everyone. We are at the conclusion of the program. I want to go over a couple of things before we end. Just want to say thank you for allowing us to come and serve and speak to you about chronic kidney disease. If you're joining us online, please do not forget to scan the QR code, sign in, as well as complete the survey. And also for our in-person attendees, if you follow us on social media, complete the survey, you do qualify to receive that $15 gift card. So see us at the table in the back. A couple of upcoming events and activities that we have. We'll be doing healthy aging. We'll be conducting a seminar on healthy aging, Alzheimer's education for caregivers. This will be at the Sunnyside Multi-Service Center on Tuesday, March 4th. That's from 10:30 a.m. to 12 p.m. So we'd love to see you out there. It will be a hybrid session where we'll be doing it in person as well as online. So we hope to see you there. Next, one of our larger conferences or larger events hosted by the TSU CEC is going to be the Clinical Research and Engagement Conference. That'll be held at TSU. That will be the week before Easter. So that's going to be on Saturday, April 12th from 9 a.m. to 3 p.m. We will have light breakfast as well as lunch provided, but also a plethora of information to provide to you, present to you. So we hope to see you guys there. Just to give you a little bit of a background, each month we host health education seminars in the Houston metro area. These are a few of our topics that we go over. And again, as stated before, some of our larger conferences, such as the breast cancer, prostate cancer, maternal child health, and clinical research, are some of our signature events on the campus. If you will, I'll give you the social media sites for you to follow us on social media, follow us to find out more information about our activities and events. And then also on Linktree, you'll be able to register for those events and activities and have the calendar ahead. You can follow us on Facebook, Instagram, Twitter, YouTube, as well as LinkedIn. All of our events are live streamed on YouTube. And then also our handle is going to be CECTX Southern U. We look forward to seeing you at our next event, and we really appreciate your time. Thank you.
Hello again. My name is Veronica Adjoale. I want to say a big thank you to each and every one of you for joining us for today's program. I am very certain that you have received a lot of great information that you will put to practice as we all grow together to become a healthier community. Thank you to our speaker and our panelists. Thank you for sharing today's content with us. Thank you to our locations. Thank you to our interns, our volunteers to our sponsors and our funders. Thank you also to the staff of our program, the faculty, and the leadership of Texas Southern University for supporting us in making today's program a success. Most importantly, I want to say thank you to each and every of you, the community members. We appreciate your support. We do not want today's program to end just with today's event. We want you to continue to collaborate with us and engage with us. Our social media platforms are located at CECTX Southern U. On those platforms, you will find engaging information from today's program and all the other programs that we have going on in the Community Engagement Corps. So we implore you to continue to stay connected with us, engage with us as we move forward together in building a healthy and a wealthy community. Thank you for joining us, and we look forward to connecting soon. Bye.